That is a very interesting question, because the most common injury that we see on MRI isn't the most common in general. If you think about films you read in the emergency department, these are PIP dislocations or open tendon lacerations, and these typically do not require advanced imaging with MRI. Dislocations are reduced and treated conservatively with immobilization, and most commonly injured tendon are in fact extensor tendons. They injure twice as common as flexors, and they often also, those injuries don't go to MRI. However, it is the flexor tendon injuries that typically get advanced imaging, because MRI in these cases provides invaluable information for the treatment. And that's why this is kind of injuries we most commonly see on MRI, the flexor, either open injuries, laceration, or closed injuries. And of that group, most common one is so-called jersey finger, is an avulsion of the flexor digitorum profundus. That is why we do the MRI, because these are bad injuries for lots of reasons. I can think of at least three. They scar fast and they're difficult to mobilize. So surgery is difficult. Also, there is a great anatomic detail about flexor anatomy. And I'm gonna share my screen for a minute to illustrate that. They have a great excursion, and therefore there are certain anatomic requirements to allow flexor tendons to glide, and also to have their own vasculature, because imagine it's very hard to vascularize moving structure. So those vascular strands, the tendon mesentery called vincula, they're placed at a certain point. So going back to tendon injuries, they scar fast. Also, those injuries typically disrupt blood supply. Imagine how easy to disrupt those tiny vinculae. And there is also a delicate interplay between the flexor digitorum superficialis and flexor digitorum profundus. You see how flexor digitorum superficialis splits and then reunites at the structure we called Kemper chiasm, and then flexor digitorum profundus passes through this aperture. So in order to repair flexor tendon injuries, they frequently require more dissection, more manipulation, and that causes significant risk for adhesions, to the point that sometimes surgeon needs to decide to repair both tendons or one, because it is better to have one tendon that glides than two that don't. So we provide a lot of information with MRI as far as planning of those injuries. And another critical portion to include in your MRI assessment is the zonal anatomy of the flexor tendons. We talk about famous no man's land, or zone 2. And why is that? What is so special? It is because this includes that critical and fairly large segment of the flexor tendons going from the insertion of the flexor digitorum superficialis to the proximal, to the distal palmar fold. Over here, this would be in margin of A1 pulley. And because of the complexity of this region anatomically and the surgical implications of that, this is called no man's land. It's no longer true. Surgeons do operate there, but there are certain implications of injuries in this area. The pitfalls, I would divide it in two categories. One is the technical pitfalls and difficulties, and the second one is interpretational pitfalls. On the technical side, it's all about optimizing your MRI imaging. And for some patient populations who have difficulties tolerating MRI, the best MRI sequence is ultrasound. So you have to choose patients, how you're going to image them and what exactly you're going to image. But if you set on MRI, there are several strategies to optimize. This includes some general principles such as optimizing patients' comfort and positioning during the scanner. We're only as good as our least motion degraded image, right? And optimizing coil selections, and also prescribing your imaging planes to the anatomy you're investigating, to prescribe them individually for the finger you're interested in, and often it helps to include the neighboring finger for internal comparison. And then, so these are kind of general principles of optimizing MRI in any body parts. But for the flexor tendons injuries we're talking about, it is also important to consider the potential extent of injury and the information you need for surgical planning. So it's important to image enough, to have your imaging area sufficient to make the diagnosis. So for example, we discussed the closed avulsion injuries of the flexor digitorum profundus, so-called Jersey finger, and it has a great possibility for retraction. And the size of the gap is the critical information for the surgical planning. So in this particular case, we could catch the distal, the expected insertion, and the proximal stump in the imaging of the finger, but it's not always the case. This the retracted tendon can go as far proximally as the palm of the hand. I often compare it to pulling the drawstrings. So surgeon needs to know how far the tendon went, and it is very important to image proximally enough. This is another example of Jersey finger when the tendon was retracted even proximally to zone 2, and patient present with the inability to flex the DIP, but also a palpable mass at the palm. So as you go into imaging those injuries, be prepared to extend your field of view more proximally to image the retracted tendon. And the second category of pitfalls is interpretational pitfalls. And this is something to do with familiarizing yourself with the anatomy of the flexor and extensor apparatus. It's quite fun, and flexors in particular, it's that interplay between the flexor digitorum superficialis and profundus. It is the tendon synovial sheath anatomy, it's the pulley anatomy, and the flexor tendon zones, which is touched upon. And there are multiple excellent sources to study on the topic, including articles from Radiographics, as well as American Journal of Radiology. And once you do that, I guarantee that imaging of the fingers would be one of your favorite areas in musculoskeletal MRI imaging.